right, good afternoon. Welcome to our 3 p.m. panel, the Uber debate of healthcare, telemedicine in Texas. My name is Kate Murphy, and I'm the Mental Health Policy Fellow at the Texas Public Policy Foundation. We're really excited to have you all here with us to talk about this very important issue facing Texas right now. It's kind of an historic time for telemedicine, especially in Texas. Last May, in May of 2015, the Texas Medical Board, and we have a panelist here from the Texas Medical Board to talk to you about this. The TMB passed new regulations surrounding telemedicine. And these regulations Texas is one of only 3 states that has these regulations in the entire country. It's made Texas, some would say, one of the most restrictive regulatory environments in the country. The Texas Medical Board passed these because of health and safety concerns surrounding telemedicine, but some others see it more as kind of almost a monopoly or cartel-like behavior that is really creating a overly burdensome regulatory environment surrounding telemedicine. If you don't know what telemedicine is, it is basically using technology to administer healthcare remotely. So that's going to be using things like phone calls, Skype, maybe wearables. There are all kinds of different ways that telemedicine is administered. And the new regulations, what they do is they require a face-to-face or in-person visit at a clinic or with a nurse practitioner or someone like that to do some of the physical examination before you can start engaging in telemedicine services. The reason this is a particularly interesting time for these regulations to have come out is there was a Supreme Court decision that came out in February of 2015. It was the North Carolina State Board of Dental Examiners versus the FTC. And in that case, the Supreme Court held that state regulatory bodies that are controlled primarily by market participants, which is the case with the Texas Medical Board, most of the people on the Texas Medical Board are doctors, are subject to federal antitrust laws. And since those regulations have been passed, the Texas Medical Board has actually been sued by one of the telemedicine companies in Texas under federal antitrust law. That case is pending right now. There's an injunction against the new rules pending the litigation. And so it's a really interesting time to see how that's unfolding. And while that's happening, at the same time, the sunset review of several of the regulatory bodies in Texas is underway. So it'll be a really interesting time to see how everything turns out with that lawsuit and how things start to unfold with the Sunset Commission and its review of how things are done by some of these regulatory bodies and licensing agencies. So I don't want to take up too much time with my opening remarks. We have a lot of wonderful panelists here to talk to you today. We're going to get started. Let me introduce you to our first panelist, Dr. Billy Phillips. Dr. Phillips is the Executive Vice President and Director for the F. Murray Hall Institute for Rural and Community Health at Texas Tech University Health Sciences Center. He is a professor of family and community medicine. In addition to his other duties, he is responsible for the direction, implementation, and overall programming of telemedicine for the multi-campus Texas Tech University Health Sciences Center. He is also a principal investigator for the Texas-Louisiana Telehealth Resource Center, one of 15 nationally chartered resource centers for the advancement and innovation in telehealth. Dr. Phillips has a long and distinguished career supporting preventative medicine and public health initiatives, which includes a substantial commitment to innovation in rural health.
Good afternoon. How are you all? I hope well. Good. Well, let me start by doing a little bit of definition so we kind of have a similar set of understandings about what we're talking about. There is telemedicine. That is an encounter between generally a physician, usually at a remote location from where the patient is, presented by another licensed healthcare professional in Texas, and that's a large category. And there's some common things that they have to do their business. Nomenclature, understanding of anatomy, physiology, things like that. So in that sense, technology is two-way talkback TV with a little more enhancement than that because we can do heart sounds and other things And so it's a great medium for exchange. The care itself is outside that particular encounter. It's really diagnosis, disposition of a treatment plan, and the establishment of an ongoing record that would meet the federal certification standards. So that's kind of one sense of what telemedicine is. There's telehealth. That's another whole matter. I love the discussion earlier because it just suggested so much that we have to think of our healthcare system now including people like community health workers, indigenous people within the community trained to help people navigate a system that's difficult to navigate. And that encounter could be anything around the concepts of health education using technology. And then there's this other new thing, not really so new, none of it's really new, is mobile health. And you know, I bet if I ask you all to take this thing out of your pocket, and you all have one, don't you? Because I saw you looking at it over there. You know, I use it, and you do too. This is a camera. It's my calendar. It's got all of those details of what my account numbers are over at the gas station and the bank and all the other things. And oh yeah, by the way, it's a phone. See, it's really an integration of a lot of applications, isn't it? So that's really what we ought to think about when we think about this general realm of what we're going to discuss today. You can even get it now where things are integrated right into your car. So I love that. I never get lost anymore, and I never have to ask directions. And that's a good thing, okay? So you get it. Now, this slide I want to set the stage. So we heard this discussion, and this is really the issue for us. We're trying to, at a federal and state level, get to better outcomes, smarter spending, and greater access to care. Now, I like to think of it like this. Over time, those are all related and true. We will achieve those. They are related to each other. In the short run, however, pick any two, because that's really more like the truth where I live and work. You know, when you think about improving quality, any physician or nurse or other healthcare provider in this audience, that is not a new term. We all went out in the first place to provide the best quality we could. Here's the difference. Today, we've decided to define that term. And things we define, we measure. And things we measure, we change, not necessarily improve. And sometimes when we do that, we discover we have to regulate the marketplace so that it is secure. So the other thing about telemedicine is it's not Skype. It's not over this mobile phone. It's very tightly controlled communications over double encrypted standard endpoints that meet HIPAA guidelines, which, by the way, you and I want, so that we have the privacy that the system requires. It's not like going to the barber. We can't just rely on a license. Yeah, I know when I get a bad haircut, but I'm not necessarily sure that I know when I get a bad procedure. I'm not necessarily sure that I know the right standard to use, because the hair grows out in about 3 weeks and I don't have much of it left anyway at this age. But what about the consequences of a breach in my health information? Might have a little different point of view on that. So the usual market drives the system approach may not work so well in certain facets of healthcare. We just need to keep those things in mind. When we think about smarter spending, you saw those graphs in the earlier presentations. You read papers and things like that. You know we've got to do something about it because all of us are aging and using those services. And oh, by the way, technology, when it's first implemented, is not cheaper. It's more expensive. and it's fraught with problems that cost more. So really, technology we want to use is technology that's old and familiar. Now, old's a relative term, and I'll illustrate that in a minute. And greater access. We can do something about this, I think. And, you've already heard about population health. Telemedicine is technology that can, not always does, address those things. So there's our environment we're working in. This is where I live and work. West Texas, and if you think about the Texas Tech University Health Science Center, we have 7 campuses. We serve 12% of the population of Texas. We're the other half of the state, 133,000 square miles. Interesting place. Those darker areas are where we have the ones and twosies of practitioners who serve their communities, physicians that are in one solo or small group practices. You can see we have shortages of every kind of provider. It's not just physicians, every kind of provider. I'm thinking of Glasscock County and a project we're doing in the Permian Basin. Thank you, Commissioner, for that help on that, with the Commission on State Emergency Communications to try to do some better treatment and triage really, of trauma that happens in the oil patch. And we're doing that in the sense because there's so few resources for emergent care there. So it's in every specialty, including my own discipline, which is primary care and public health. So we live this reality, and I'm going to tell you that regardless of what all the rules and regulations say on the ground, we have a very integrated healthcare system in the sense of providers because we all have to play. Nurse practitioners are important out there. So when you look at it, what we have to do is use technology to bring care closest to home and care that can be delivered by the most trained but least expensive of the providers and that can be qualitatively efficient. Now I'm going to tell you a story. When you look, and this is from reality, so this will not match any patient we have in our system, but I want to illustrate the concept here of just two interrelated policy issues. This is West Texas. So if you look at the distance from Presidio, where there's a recently reinvigorated federally qualified health center with 5 docs and 9 nurse practitioners, what you find is if you have a patient there who needs subspecialty services, they are going to have to come to Lubbock because that's where the providers are that will see Medicaid clients. And so that's 360 miles, about a 6-hour drive, at least the way I drive. If you take a client in El Paso who needs, say, dermatologic services, it's the same thing because none of the dermatologists in that community as of about a year ago would take Medicaid. And so where do those people come? Is this a good application for telemedicine? I bet we'd all say, hey, you know what? That is a good application because people don't have to travel. They don't lose wages because they take off work. Kids don't miss school. And we can engage them, triage them, and begin a treatment plan that makes a certain amount of sense. Now, if you look at this one, those blue circles are also 360 miles. So take a client that lives in Houston that needs those same subspecialty or specialty services. In that 360 miles, that client would have options for care in Houston, Galveston, San Antonio, Austin, Waco, Fort Worth, and Dallas. So when we look at access to care, the options are much greater for those kinds of clients. So yes, does this technology link people? It does. That's the great thing about it. It's now very old technology. And I would just say, don't lose the idea that the reason practitioners don't take Medicaid rates is they can't deliver the services for that rate. they lose money, and therefore they have to be in business, they have to pay bills, fewer of them will accept those reimbursement rates. So maybe there's another policy issue there. So here's the deal. We have a technology in telemedicine that began to be dreamed about in what's illustrated there on the radio news article of April 1924, where people were beginning to talk about it. The TV, the first cathode ray tube, was illustrated in that issue. And then you take the guys there on the right, that's shuttle pilot Mike McCulley. They were getting baseline data on him in our NASA lab when I was at UTMB. We now do that by a console connect to all flights that were flying when we flew, and we did it by telemedicine. And so in just that brief period of time, you can do the math as well as I can, but about 60 years, we went, to a place where we could deliver that kind of care in outer space. Then come along this personal communication device that we all have in our pocket, the smartphone. And really 1992 is when it was introduced, but Apple made it famous. So in just that small amount of time, 1/3 the time, we went with the capacity to be mobile with health care. And now, just think of what is going to happen and what does happen when you can connect to a physician immediately for some kind of dispositional care for some kinds of conditions. Could there be hazards in that? You can think of them as well as I can. Should we regulate that? Maybe, maybe not. I know one thing, if I'm going to use this as an EKG, I want it to be accurate. Is it always accurate? Well, how many calls have you had dropped? How many? Think about it. This is a technology. These are old technologies. The older, the better, because we've had more time to get the kinks out. I'm going to end up with some suggestions for you. First of all, telemedicine should be value added if we're going to do it. It ought to be compared to in-person care and the value of that. If that fails, then it's something else we should do. Secondly, telemedicine should be safe and secure. It's not like going to the barber. It isn't very subject to market-driven forces. Should we be smarter about incorporating market forces? I love that idea from the back, and I'm sorry I didn't catch your name, but from Tyler, I love that idea. Yes, we should, but it better be safe and secure because you may not want that information out there in the public domain. And telemedicine should be held to a standard of competency in education so that we can have a standard of competency in care. You see, the secret is this, the myth is this. You think we're all trained to do telemedicine because we can, but we're not. If I told you how little training we now do, and most of that in the last 6 years, we built the first telemedicine training lab at Texas Tech University Health Science Center. We opened it last month. We will train to a standard because we must have a standard of care. And finally, telemedicine should not be regulated because it's new and edgy, because it's not. It shouldn't be regulated to eliminate the possibility that we make it new and edgy in the context of safety and security. Thank you very much for letting me talk.
Next up, we're going to be hearing from Dr. Elliot Justin. Dr. Elliot Justin was founder and CMO of SwiftMD, a telemedicine firm that provides on-demand access to physicians. Dr. Elliot Justin is a residency-trained, board-certified emergency medicine specialist with over 30 years of experience as a physician, departmental director, and corporate leadership. In 2008, Dr. Justin established Pegasus Emergency Group, his third successful venture in emergency medicine services, which he sold in 2014. Dr. Justin spearheaded a number of key initiatives to improve pre-hospital emergency care in New Jersey, including the use of automatic external defibrillators, or AEDs. That could get really exciting.
Explosive results.
By first providers and rapid sequence intubation by paramedics. In 2004, his peers in New Jersey elected him the American College Emergency Physician EMS Doctor of the Year. He holds a bachelor's degree in Slavic languages and literature from Harvard University and a doctorate of medicine from Boston University in Boston, Massachusetts. He's trained in emergency medicine at Hennepin County Medical Center in Minneapolis, Minnesota from 1979 to 1982. Please welcome Dr. Elliot Justin.
Thanks for the recap of my life. I've lived in Montana for almost 2 decades now, but I want to apologize. I'm originally from New York, tend to speak fast and talk like an alien, so don't just keep track of the time there. If I'm going too fast, don't tell me to slow down. So, telemedicine. After the gentleman was talking about the smartphone, I call where we want to go smart care. When people are ill or worried, what do they want most? They want timely advice and or prescription. Yet commonly they have to struggle to get those things. Now in every other area of the economy, access, quality, choices at reasonable prices abound. Clothing, food, hotels, transportation, phones, computers, even home repairs. Yet in healthcare, this is difficult. Why? Well, I think in order to change things, we need to take healthcare out of the 19th century into the 21st century, out of a world that is doctor-focused, brick-and-mortar-focused, into a world that's consumer-focused and uses computers to say diagnosis to help people make decisions. This tool, as the gentleman said before, is in everyone's pocket or in everyone's lap. And the first step, to my mind, is doctor-to-consumer care. But the second step, and I'm going to talk about this later on, is to go beyond doctor-to-consumer care and to liberate people to take care of themselves for common problems, even to self-prescribe for common problems. Telemedicine transcends the shortage of physicians and can take full advantage of the innovations that the 21st century will allow in healthcare. We talk about remote blood pressure, for people with high blood pressure. Instead of going to the doctor twice a year to get your blood pressure checked, you get your blood pressure checked 24/7. That information could go to a physician, or ideally it could be managed by the consumer on their own. I mean, the doctors are working off algorithms. This can work off algorithms too and tell you whether or not you need to go up or down your blood pressure medicine. Same thing, blood sugar, pulse oximetry, and peak flow meters for helping people with asthma decide whether or not they need to change their medications, they add a steroid, change their inhaler, et cetera. So telemedicine delivers care that is high in quality, timely, more accessible, and less expensive. Issues of personnel, lack of personnel, space, and time disappear. The budget crisis disappears as well too, because we now can manage people without costly offices and costly tests. Anyway, let me get my. It's already here. I mean, this is an incomplete list of all the companies that are practicing telemedicine in the United States. They're here in Texas. They might be here legally or not legally, but they're here. And millions of Americans are not just ready for telemedicine, they're doing it. They're doing it right now. There are millions and millions of contacts annually, probably a couple million contacts annually for primary care and urgent care needs. With SwiftNV, we've had thousands and thousands of calls. We've had no complaints. We've had no malpractice issues. I think the Teladoc, which is about 10 times the size of this, makes a similar claim. People commonly express a wish they could have a doctor in their family, a loyal, unbiased diagnostician help them navigate the complex healthcare system. Well, since this is 2015 and not 1915, everyone can now have a doctor in their family, a virtual doctor. This doctor is armed with the latest objective knowledge. This doctor is available 24/7 everywhere. You don't have to go to a doctor's office. This thing can be in your office, can be in your car. This thing doesn't care if you call. Are there any doctors here? You like being called 2 o'clock in the morning? Like being called 2 o'clock in the morning for poison ivy? Well, this tool doesn't care about any of those issues. 2 o'clock in the morning is fine. Minor complaints are fine. It doesn't care about whether you have insurance, whether you can pay or not pay, your race, your gender. All these things are irrelevant to this tool. This tool also never upcodes, and this tool doesn't care about reimbursement. So I call this smart care. I call it healthcare at the speed of life. What is healthcare at the speed of life? Healthcare at the speed of life is in real time, it's on time. An additional profound benefit of telemedicine addressing common issues and urgencies is that now physicians, with their knowledge capital and the years of training, are freed up to take care of people that are very sick and have complicated issues of chronic illness. So but with telemedicine, we can unleash this other resource. Anyway, let's just review for a moment why patients so often can't get what they want for their common problems. Well, managed care and Medicare don't care about what they want. What do people want? They want advice. What do managed care and Medicare pay for advice? They pay nothing. Now, when you pay nothing, you get nothing. So it doesn't take a Texas Public Policy Foundation white paper to figure out why this is a problem. It doesn't take Paul Krugman might struggle with this, but it's not difficult. If people, try calling your ER, your urgent care center, even your personal doctor just for advice only. If they were paid for it, they would deliver it, but they're not paid for it, so they bring you in, and when they bring you in, costs tend to explode. Another problem with managed care and Medicare is after advice, what people most want is quality and access. Well, as I said before, unlike other areas of the economy where payment is related to quality and access, hotels, restaurants, services, etc., Medicare and Medicaid and managed care pay the same amount of money for the same service, regardless of quality, regardless of outcome, regardless of empathy, regardless of experience of the people that delivering that. Now again, you don't need a Texas Public Policy Foundation to predict that if you're going to pay the same amount for the same service, regardless of the outcome, regardless of its quality, quality is going to deteriorate. Now this is how we pay government. Is that working? Imagine if we paid for other services this way. Imagine we paid for hotels, restaurants, groceries, repair for our homes, beer, football teams. Imagine if we just paid the same amount for the same service regardless of outcome. The results would be unacceptable to us, and yet this is what we do in healthcare, so we shouldn't be surprised by the mediocrity that is often the result. Medicare, Medicaid, managed care pay little for time providers, which is what people want most. And yet they pay too much for tests and procedures. So what do you get? You go to the VA, you get 8 minutes with your primary care doctor. You're in a primary care office in Bozeman, Montana, you get 10 minutes, maybe 11 minutes, but you get a CAT scan, a lot. And I think the restriction of competition from telemedicine and paramedical providers also perpetuates this problem because we need competition in order for things to change. So do we really need expensive, highly educated doctors examining patients through the largely worthless ritual of the ophthalmoscope, the stethoscope, the reflex hammer, screening tests, and annual exams? We have to ask ourselves, can't these things be done by patients themselves with the aid of apps? Can't these things be done by less expensive technicians? I firmly believe that when telemedicine and technicians can substitute for expensive physicians, prices and costs will tumble and the quality of healthcare will improve. Most people just need a doctor 2, perhaps 3 times a year. They have a minor infection, they have a sports or work injury, they want to know if they need an antibiotic, do I need an x-ray, they need a med refill, they need some coaching, they need their blood pressure medication adjusted. Do they really need to go to an office visit to a doctor to get these needs addressed? Studies indicate that more than 65% of patients in ERs and 85% of patients in doctors' offices just need advice or a prescription. Doctors say they can't diagnose over the phone, but how often is that really true? Is that what we tell family and friends? When my Aunt Patty calls me up and tells me she sprained her ankle, do I tell her, I need to see that. I need to get an x-ray. No, I ask my Aunt Patty, can you stand on your leg? Can you walk 3 steps? Is it tender on the outside of your foot? And she says no, but it's really swollen and hurts. And I tell her, put ice on it, take Advil. I'm more compassionate than that when I talk to her. I say Patty. But I think you get the point. The doctors and their families almost never see doctors for a sore throat, a urinary tract infection, a yeast infection, for an ankle sprain. Why not? They have a doctor in their family. They're privileged with knowledge and access, and it's time we extend that knowledge, that privilege, that knowledge and access to everyone by letting people take care of their common problems using smartphone with approved applications. And I looked to the telehealth centers, the research centers, to start developing these apps. I mean, there is IBM Watson. There are other, SwiftMD has tools that we don't use, what we developed. There are the tools out there. We can make this tool smart, effective for everyone. So, what are the barriers? Well, when we're not allowed to self-diagnose and self-prescribe for common problems. I see this as a huge opportunity. We shouldn't be restricting, we shouldn't be banning, but we should be experimenting. I think this is an opportunity here in Texas to demonstrate the safety and effectiveness, not just of doctor-to-consumer telemedicine, but patients taking care of themselves. Pick 10 or 15 common diagnoses: back pain, ankle sprain, urinary tract infection, yeast infection, sore throat. Pick 10 of them, form a committee, or use some of the applications that already exist. Agree that this is the right pathway. Agree that we're going to have an algorithm, a yes/no algorithm, where a pilot group of patients could utilize healthcare in this way. I'm confident that utilization of ERs, urgent care centers, physician offices will plummet. I'm confident it'll be less expensive. I'm confident the quality will be just the same. As a matter of fact, it might be better. Licensing. I'm from Montana. Why do I have to drive to Cheyenne, Wyoming to get a medical license? Why can't a doctor from, is medicine so bad in New York that a doctor from New York can't quickly get a license here in Texas? If a doctor's licensed in 25 states outside of Texas, why isn't there an expedited process? I'm not just picking on Texas. This problem is everywhere. Licenses are expensive, they're difficult. I mean, there's one state that wants you to produce a high school diploma. Good luck digging up your original high school diploma today. So, and also healthcare standards today are national. So this area is enormously frustrating. And if we're going to have effective telemedicine, if you're going to have doctors, high quality doctors are going to have licenses in 10, 15, 25, 30 states, you can't be charging them $500, $800, $1,000 a pop, for those licenses. Guild restrictions. So many of the procedures in healthcare are easy to perform. If we want to free up the knowledge capital of physicians to take care of people who are really sick, to deal with the person who has chronic illness, that are multi-chronic illnesses that are complicated, why is that doctor lancing a nail for a hematoma? Why is that doctor sewing up a 2-centimeter laceration? It's absurd. These things should be done by technicians. I mean, I'll share with you something a little bit embarrassing just because it comes to mind immediately. Mom, don't listen. I had a hemorrhoid a couple of years ago. To get a hemorrhoid done by a gastroenterologist in Bozeman, Montana was $640. This is a little prick. Why can't I go to Harry the hemorrhoid shop and get it done for $25? Common concerns. Telemedicine is not a pill mill. If we are going to be prescribing sleepers and narcotics, the amount needs to be restricted. SwiftMD started doing this. It does not do this anymore because of concerns about regulatory issues in the various states. But we never had a patient request more than one, and this is an issue that can be managed. Does telemedicine replace primary care? No, it doesn't. It does not. Pre-existing relationships. Well, to treat somebody for minor urgencies, a cough, pink eye, ankle sprain, yeast infection, poison ivy, do you really need a pre-existing relationship? Why do you need any relationship at all? It's just not dangerous. In my view, and we should test this. This should be done quickly with a study. I'm confident it's going to prove to be safe, effective, and inexpensive. Doctors take care of friends and family. over the phone. This should not be a privilege. Everyone should have the right to do this. People in Washington or here in Austin or Helena, Montana, they should empower consumers, not constrain them. Time is up. I will just quickly show this slide, the Texas way versus the DC way. Let individuals choose their providers for routine and urgent care. Empower consumers with the knowledge that physicians have with computers. And let innovation flourish. Innovation will improve quality, access, and reduce costs. Thank you.
Next up, we are going to hear from Mari Robinson, who is the Executive Director for the Texas Medical Board. Prior to joining the agency, she worked for a short time in private practice in the area of civil litigation, as well as for the Texas Attorney General's office. She has served on several Federation of state medical boards, including the Interstate Medical Licensure Compact Planning Group, now known as the Interstate Compact Task Force, the Advisory Council, and the Board Attorney Workshop Committee. She is an active member of the Administrators in Medicine and currently serves as the chair of the Certified Board Investigator Committee. She has a law degree from the University of Texas Law School and has previously served as an adjunct instructor in the school's advocacy program. Please welcome Mari Robinson.
Clicker?
Do I take it? I'm sorry.
No problem.
Just trying to manipulate things now.
That's all right, no problem. I am Mari Robinson. I'm the Executive Director of the Texas Medical Board. And actually, before I start my slides, I want to pick up on something that Dr. Justin said related to trying to make it easier to get licensed in other states. And that is actually something that is being pressed forward right now with the AMA and the Federation of State Medical Boards, the idea of an interstate compact, whereas if you are licensed in another state and you meet certain quality standards, you will be able to be almost immediately licensed in any other state that's participating. Right now, 12 states are, and I think Montana is one of those. So good news, I don't think you have to drive to the Capitol. You might want to check it out. It might be easier for you. The first slide in every presentation I always give is this one. It's the board's mission statement. It's pretty straightforward. It's to protect and enhance the public's health, safety, and welfare through licensure, discipline, and education. It's exactly what you expect. The reason I start with this slide every time is because the board takes this mission very seriously. Every license they talk about issuing, every disciplinary action they take, every rule they discuss, this is what it comes back to. And if you attend board meetings, you hear them have this discussion. How will this protect the public? How will this enable safe and effective health care in the state of Texas? Now, the rule that we are talking about in Texas related to telemedicine is Board Rule 174. And good news, telemedicine is absolutely allowed in the state of Texas, despite what some of the newspaper articles might say. There are two primary principles that underlie this. Number one, you've got to have a license in this state if you're going to practice on Texas citizens. That's true in every state in the nation. So that's not unique to Texas, and it's not unique to telemedicine. That's pretty much been the rule since the board was instituted in 1901. Obviously, that is to allow the government to hold accountability to folks who are treating their patients. Second, there's got to be an adequate diagnostic information gathered through a physical exam, accepting mental health services in most cases. So this is how this plays out. There are two essential models to receiving telemedicine in Texas, and they both start with this idea of establishing a relationship. First, you can do it what is sort of being referred to as the old-fashioned way. You can go to a brick-and-mortar doctor's office. You can meet him for the first time or meet her for the first time. You can have that physical exam, get the appropriate diagnosis for whatever is currently going on with you. Once you have done that, you have established a physician-patient relationship, and you can do follow-up with that physician or people covering for that physician in call coverage for up to a year. Now, part of this is because this doctor now has your physical information. They know what you weigh. They've done an exam of all of the things that they need to look at to get an accurate medical history of you. They know your medical history. They've discussed it with you. They've made appropriate diagnosis. They've got your blood pressure. If they've done the appropriate blood work, they've got your blood sugar levels. They have all of that information that they need to make those diagnoses. So, for example, if you have that initial diagnosis and you are diagnosed at that time with hypertension, which was an example mentioned earlier, you can do follow-up for that for up to a year without needing to go back to that office. Obviously, that follow-up needs to conform to the standard of care, and it needs to be recorded in the medical record. But it's an accountable system. It's a way for a physician to treat you, and you don't have to drive the 200 miles to see your physician every 3 months for hypertension. But it is a safe way to do it because there is an accountability there, there's a history there, and there's an ongoing basis for care. That's what the rule contemplates. The other way to do it is to see the patient through what's called an established site. And Dr. Phillips's programs have a lot of these all throughout the state. It doesn't require a doctor to be there. It's any licensed or certified healthcare provider. It's a very broad category in our state. So it doesn't have to be an APN. It doesn't have to be a PA. It can be an LVN. It can be an EMT. It can be a mental health certified provider. It's an enormous group of healthcare providers. Tens of thousands, I dare say hundreds of thousands, meet this qualification. And they are at the established site. There is sufficient technology to be able to relay information to the physician or PA or APN on the other end. They get the diagnostic information via this setup at this established site. You have to have that computer, that ability to see back and forth, and you have to have the appropriate diagnostic pieces of technology, the peripherals. There are all kinds of peripherals that exist nowadays. It's really very amazing how far technology has come. But just like you can plug a mouse into a computer, you can plug in a peripheral that will let a doctor listen to your lungs. It will let an APN listen to your heart. It will let a PA hear your pulse, your respiratory rate. All of that information can be gathered through an established site, so you don't have to travel to the specific doctor's office. That same location, that established site, can absolutely be used to create the same physician care or the physician-patient relationship or APN-PA relationship that you would create in the brick-and-mortar site. You're using the virtual technology to get the same information to meet the same standard of care that you would in person. And the board's perspective is telemedicine is a method of care. It's not a branch in and of itself. It's a way to provide care. The standard of care for telemedicine is the same as the standard of care for in-person visits. If it wouldn't be sufficient for an in-person visit, it's not going to be sufficient for telemedicine. So if you went to the doctor's office and the doctor was sitting on the inside of the office and you were on the other side of the door, they didn't actually see you. You wrote your symptoms down on a piece of paper, slid them under the door, and they wrote back to you a prescription and you walked out, the board would not consider that to be an adequate evaluation, regardless of whether it was in person or not. Something like that through telemedicine is also not considered to be an adequate evaluation. If the evaluation is adequate, if the exam is done, it doesn't matter if it's done via telemedicine or in person, as long as the physical exam is done to get the appropriate information to the healthcare provider, in this case I mean doctor, physician, PA, to make an adequate diagnosis. Once that is done, you can absolutely do follow-up for up to a year the same way that you can do if you had seen that initial provider in person. Additionally, if you have more symptoms develop over the course of that year, that healthcare provider can treat you for up to 72 hours for those symptoms, and assuming they resolve, there's absolutely no problem with that either. The only time you're going to have to go back to the established site or the in-person is when you've got symptoms that are developing. They're not resolving or being addressed with that initial evaluation or look at by the doctor. Then you're going to have to go back and get some additional follow-up because the initial treatment clearly isn't effective. So I want to give a few examples. First of all, a patient comes to a rural hospital suffering from symptoms of a stroke, but there's no neurologist on call. This is very, very common. Neurologists are pretty rare in the state of Texas when you're overall looking at the amount of providers that we have. And those are sort of the folks you want to be talking to if you're having symptoms of a stroke. So can the hospital contact a neurologist via telemedicine and allow the patient to be evaluated and treated? Yeah, absolutely. That's one of the primary things that telemedicine is intended to do. It's intended to allow access to specialists that are not common, particularly in rural areas. So when you heard Dr. Phillips earlier saying, imagine that you're in this FQHC, this federally qualified health center in the middle of West Texas, and there's no one nearby that's a specialist that can see you. There are specialists in Amarillo, there are specialists in Midland, there are specialists in El Paso. Great. You can access every last one of those specialists through this FQ, the Federally Qualified Health Center in your small town. That is absolutely possible and encouraged, and it's a great way for people to access the specialties that they're already not. But the fact is, it doesn't even have to be a federally qualified health center. Even those can be incredibly rare in certain parts of the state. It could be a pharmacy. If the pharmacy had the setup, had the appropriate diagnostic peripherals. In fact, a pharmacy is ideal. You've got a healthcare provider right there. If the person is sick enough, they're going to need a prescription, they have to go there anyway, right? If they need immediate medicine, it's not just going to appear in their mailbox. So this is a great place to do this. A school is another prime example that would be great for this. Representative Laubenberg passed a bill last session that contemplated this and actually put this out and said, look, let's start establishing some of these sites in schools where they have nurses' offices. Great. This will allow kids to be able to be seen by PAs, APNs, physicians, assuming, the appropriate consents from the parents are received and all of that stuff is in order. That would be true for any care. But this would allow that to happen. Oil rigs, absolutely. Great example. This is a prime place for something like an established site. Those folks are out in the middle of the ocean. There's no way to get them back. What you would do is before they shipped out, they would be examined, which they're going to be anyway, because you want to make sure you're not sending somebody sick out to the middle of the ocean. Get that diagnostic baseline in place, and then use the established site on the oil rig to get that information back to that practice, that care provider, that PA, that APN, that doctor. Example number 2, a patient is seen by a physician for an annual checkup but is diagnosed with a chronic condition. Can they do follow-up with the physician using telemedicine from their home? Absolutely. It's fully anticipated that as the population ages, we're going to see a larger and larger sort of overall percentage of the population having these types of chronic conditions that need monthly sort of follow-up, but we don't want to overwhelm doctors' offices having somebody go in every month. That's the idea that Dr. Phillips was alluding to with telemonitoring. There have been plenty of bills passed on this as well, with the idea that we can have a constant feedback loop to a medical office where a patient has that medical home. It doesn't require them to come in every time, but they've got that good baseline. There's an accountability system. Any provider who wants to help that patient has access to all their records. They see the full picture, and good care can be given. Example 3, a patient wishes to receive mental health services from their home. Is this permitted? Yes, absolutely. Because when you're thinking about mental health services, this is not something that traditionally requires an extensive in-person evaluation, and it's certainly something that you don't want an assistant there for, right? This is a one-on-one relationship between the person providing those counseling or mental health services and the patient themselves. There are 2 exceptions to this. Number 1, if there is a physical exam dictated for a behavioral emergency, that's defined by statute. That, to be blunt, means they're going to hurt themselves or someone else pretty quickly. Obviously, those people need to be seen. They need to be seen in person. They've got potential for being admitted. This is a serious thing. Number 2, and this goes back to what was mentioned earlier, it is illegal under federal law to prescribe a controlled substance over the phone. That doesn't have anything to do with state law. That's the DEA. Anything that is a scheduled drug 2 through 5, and that's a lot of psychotropic medications, they can't prescribe them over the phone. It's just not permitted under federal law as it stands right now. Number 4, the physician wishes to provide services to homebound patients without making them come in the office. Well, an LVN with the practice visits the patients, takes a laptop with her, diagnostic peripherals, and sends the information back to that physician. Is this allowed? Yes, absolutely. This is another great system that could be set up in some of the more remote areas, particularly for homebound patients. As I said earlier, the amount of diagnostic peripherals that are coming out is increasing every single day. These things are portable. When we first passed telemedicine rules, which was actually in 2010, the example that we were given was a box that was like 4 feet by 3 feet. It weighed about 1,000 pounds, and really only hospitals had them. But in the 5 short years since 2010 that we've had that, the peripherals have exploded. And so it is absolutely possible to hire an LVN, to hire an EMT, to hire a certified health provider, to go to different homes and allow them to contact back with an APN, PA, or a physician at a practice, give them the diagnostic information they need to make the appropriate diagnosis. So there are all types of expansive telemedicine in the state of Texas. And I'll finish by saying, the board is actually currently working on the rules, and they're looking at other ways. We've got a standing stakeholder group. Dr. Phillips is on it. Folks from the eHealth Alliance is on it. American Well is on it. There's over 20 stakeholders on this group and have been for 5 years now. Technology will continue to evolve. The board knows this. The board will continue to evolve these rules as technology does. Everyone keeps referencing the phone, which is great. I would mention the people most underserved do not have smartphones, okay? The elderly poor who are in the middle of West Texas don't have an Apple VI. Maybe someday soon they will, but they don't as it stands right now. However, they are testing things in Great Britain right now. They are testing things coming out of a company in Georgia that allow you to put blood on what is a stick and let your iPhone analyze that. Great. Get those test results back to a healthcare provider who can help you do that. As these things evolve, we'll see more and more of that. Thank you so much. Thank you.
All right. Some of you may be wondering why our Commissioner of Agriculture is here. I think that has been touched. I'll let him expand on it more than I'm going to, but I think that's been touched on a lot with all of the discussion of access, particularly in our rural communities. And that's part of the reason that telemedicine is so important and is becoming increasingly more important, is because it provides opportunities for access for our rural and frontier communities, as well as for people in other places. But let me introduce Commissioner Sid Miller. He is the Texas Agriculture Commissioner, serving as the 12th Texas Commissioner of Agriculture. He has served 6 terms as a member of the Texas House of Representatives. As a leader of the Texas Department of Agriculture, Commissioner Miller is working to safeguard water resources, to ensure access for farmers and ranchers, as well as fighting to secure our nation's porous border with Mexico. Graduate of Tarleton State University in Stevensville, where he received a Bachelor of Science in Vocational Agriculture Education. Please welcome Commissioner Miller.
Thank you very much. I guess you are wondering why the farm boss is here to talk about telemedicine.
Vets make good doctors.
There you go. Well, at the TDA, we actually perform about 130 different functions. The obvious stuff that you think we do when you go in the grocery store and pick up a carton of eggs, we make sure it doesn't have E. coli or salmonella, or you pull a gallon of organic milk out of the refrigerator. We're the ones that make sure that it doesn't have antibiotics or hormones in it. But then kind of beyond that, people kind of have no idea what we do at TDA. We're also over all the weights and measures. So we're the ones that inspect over 400,000 fuel pumps to make sure you're not getting cheated at the gas pump. We do all the scales in the state, whether it be at the grocery store scales or scales at the tobacco shop or Starbucks or the lumber yard or The yogurt shop, all those are registered with us. People that buy and sell gold, they have to register with us. People that buy scrap metal, all of those. How many of you play the lottery? Anybody? Did you see where it was up to $450 million? Anybody see that? No? Yeah, you might want to buy a ticket.
Wait till he's done speaking, though. Wait till he's done speaking.
We're the Consumer Protection Agency. We inspect the lottery balls, make sure you're not getting cheated. That's a honest game of chance. We run 12 of the 14 federal nutritional programs. Some you'd be familiar with: school lunch program, school breakfast program, summer feeding programs, Meals on Wheels. We're responsible for feeding 4.2 million school kids 2 meals a day every school day. We have a bank at TDA. We do infrastructure grants to rural communities, cities, and water districts and things like that. We have a water department. But we also have the Department of Rural Health Care. We're in charge of rural health care, delivering grants, infrastructure, retainage, recruiting for 177 counties across the state of Texas. And our population is a little over 26 million, with 3 million of those live in these 177 counties, which makes up 85% of the geographical region of Texas. The population that lives in rural Texas is much older, so their conditions tend to be more chronic, and they have more health care needs. 75% of Texas counties are federally designated as health professional shortage areas or medically underserved areas. We've recently had 12 hospitals closed. Well, actually 13. There's one closed in November in Bowie, Texas. That was a loss of 100 jobs at the hospital. And industry looks like they're going to pull out and move 300 jobs because there's no emergency room for their employees. You take 400 jobs out of a small town like Bowie, that just pretty much kills it. These little towns, they need 4 things to survive. They need a public school. When those schools close down, the community closed down. They need a church to be grounded in. They need a bank to do commerce. And they need a hospital, or at a minimum, a doctor and a clinic. So anytime one of those 4 legs of that is kicked out from under them, those communities start to collapse. So that's why rural health care is so important here in Texas. Texas rural hospitals provide health care for 15% of the state's population. Population density and a distance means that 64 of the 254 counties of Texas don't have a hospital. We have 64 counties that do not have a hospital. Let me just tell you a little personal experience on that. Most of you don't know me, but when I'm not up here running the Texas Department of Agriculture, I'm a rodeo cowboy. So not so recently, but kind of recently, I was in Giddings, Texas. And I was roping there and had a rodeo accident and dislocated my elbow. Well, the EMTs were Johnny on the spot and come pick me up and put me in the ambulance. And they said, "Whew, that should be going north and south instead of east and west. We probably need to take you to the hospital." I said, "Okay, let's go. I'm for that." So off we go. And we drive. And I said, "How far is it to the hospital here in Giddings?" They said, "Oh, we don't have one." I said, "Where are we going?" "To Brenham." It took me over 40 miles to the nearest. You think Giddings, that sounds like, everybody, if you're around here, you know where that is. It's a pretty sizable little town. You'd think they'd have a hospital. They do not. So, by the way, Brenham doesn't have a taxi service. So if you ever get stranded there and your horse trailer is in Giddings, you might want to have a plan other than calling your wife and tell her you're in the emergency room. I was at another event in Clarendon, Texas. Anybody know where that is? Up kind of in the Panhandle. There's a college there, Clarendon College, and had another rodeo accident and had a pretty deep laceration. So they got me and put me in the ambulance and cleaned me all up and said, "Oh, I don't think we can fix that. You're going to have to go to the hospital." I said, "Good, let's go. I'm for that." And they said, "Well, we don't take you to the hospital." "You don't?" "No, we don't leave Clarendon." "Well, where's the hospital?" They said, "Well, the closest one's in Pampa. That's over 50 miles. So I had to get one of my cowboy buddies to load me in the pickup, and we drove to Pampa. And so if we'd had telemedicine, they could have hooked up with those EMTs there and say, "Hey, clean that up and fill it full of Dermabond and close it shut, send him home. That's all they did. So that's kind of my personal experiences with being in some of these, and those are not small towns. You can think of some of the very, very small ones out. If you have a deer lease somewhere out around Gymnet or Sonora out there, there's some really remote places. Those aren't really remote in my mind. It's an economic issue to rural Texas too. Rural hospitals are often the second or sometimes at least the third largest employer in the city or the county. Rural health care is been over at the TDA for a few years, but it's never really had a high priority. When I took over as Agriculture Commissioner, I made it one of my highest priorities because there's no excuse for anyone in the state of Texas not having proper medical care or access to proper medical care. So that's why I've hired a special assistant commissioner in charge of rural health care. He's working with Dr. Phillips. He mentioned that we have a pilot program with him out there where we have this program running in 9 counties out there in West Texas, a lot of it in the Permian Basin. So we've put the double encrypted communications equipment in those emergency vehicles where they can talk directly and securely back and forth to the Texas Tech Medical Center. And we think that's critical, especially in the oil field where you have a lot of burn victims. Those first 15 or 20 minutes, the treatment is critical. Most of those drilling locations are not within 15 or 20 minutes of a hospital. We were also partnering, Dr. Phillips, I don't know if you knew this or not, but with the Shriners Burn Hospital in Galveston. I know you used to be related with them. We have a telemedicine pilot project with them where we're trying to get them hooked up into rural parts of Texas. It is challenging. They can Skype a patient in Peru and do telemedicine there, but they can't do that to someone in Pecos, Texas because of our HIPAA laws. And you can argue that's good or bad, but it is a hurdle that we have to get over. So we're working with them, and they told me that the head doctor down there, and I'm certainly not a medical person, he said that other than being a first responder and getting that critical access to that person, he says the next most horrendous thing is once that patient leaves our facility and then has to drive back in. He said the ride back up here for a burn victim to get a re-examination or a consultation 100 or 200 miles is just excruciating. He said if we were allowed to do that through telemedicine, we could save those patients a lot of pain and agony. So we're, kind of facing reality. We're not getting any new hospitals in rural Texas. Very few new doctors or nurses or pharmacists. So this is our next best thing and a tool that we're going to have to utilize and get over these regulatory hurdles. But it's not just rural Texas that needs it. Everybody needs it. Urban, suburban, huge advantages to big companies, corporations, where they can have telemedicine for all of their employees right there on site. They don't even have to go home. They can get on it, get their diagnosis. They can be treated much cheaper for the company too, and a better preventative health care outcome for the employees. So to me, it looks like a win-win for all of Texas, for rural Texas. It's one of the have-to choices that we have to do. For our urban friends and suburban friends and people in the corporate world, it's an outstanding service that we need to utilize a lot more. So as I close, just remember that Texas agriculture matters. Thank you. God bless you.
I want to say another quick thank you to our panelists. This panel, we're about to open up the floor to questions, but I'm going to ask one before I let you guys have at it. We called this panel the Uber debate of healthcare because it reminds me a lot of some of the debates surrounding Uber. I don't know how many of you, most of you are probably familiar with the car services Uber and Lyft. They are generally cheaper than taxi services. They provide much needed assistance or a much needed service to urban communities. And I see telemedicine in a very similar way. It's often cheaper, and it clearly, from what I think you've heard across the board, provides much needed service and much needed access to care, to specialists, to providers generally. And Mary Robinson talked about some of the regulations that are new in Texas, including Rule 174, which requires a pre-existing relationship before you start engaging in telemedicine services. Not that telemedicine services aren't available, but that needs to take place first. And that is the regulation I alluded to earlier when I was talking about how there are only three states in the country that have that regulation. Only Texas, Alabama, and Arkansas have that strong of a restriction on telemedicine services. And I guess my question, specifically to you, but to other panelists too, is why is telemedicine less safe in Texas than in those other 47 states?
And actually, I would say to you, I don't think that number is accurate. What has happened in a lot of states is what they do is just take an enforcement action against any doctor who is not establishing the physician-patient relationship first. They didn't pass a rule telling people this is what we think the standard is. They just enforce that standard. And so it's not necessarily that the standard is different in every state. It is absolutely true that different states have different rules, and there are some states that are more lax than others. But when you do the really deep dive and you look at what standard those states hold those licensees to, a huge amount of them, more than 3, and I'm happy to share that research with you after this, require that. They require some sort of physical exam to establish that relationship. And actually, it's not fully accurate to say that you have to have the relationship before telemedicine, because you can establish that relationship through telemedicine, through the established site like what we were talking about. And certainly those burn victims that Commissioner Miller was talking about could absolutely be seen via telemedicine for our follow-up. They don't have to go back to that hospital. So I think part of the problem that we're seeing in our state is education. I mean, I've talked to hospital after hospital that they think that something is prohibited that isn't. And part of that is because of the way this is played out in the media. We've done talks with THA and things like that to try to get more information out there. And I was talking to Dr. Phillips as Commissioner Miller was speaking about, can we create some education for the folks that Commissioner Miller was talking about in those hospitals so we can help them know how to expand all of this. But this is pretty much an established standard of care. The board did not make that up. The idea that you would take someone's blood pressure before you diagnose them with hypertension, the idea that you would examine a child, particularly a baby, before you diagnose them, that is not a new standard of care. That is not new. That is a standard of care that has been around for a very long time. The board didn't create it by creating Rule 210. Changing the rules in 2010. So that would be my overall response to that.
Can I speak?
Yes, please.
Yeah, I don't know any telemedicine company that takes care of kids, of neonates and newborns. Not really what we're talking about. The 2 most common problems that bring people to urgent care centers in the United States are upper respiratory infection and ankle sprain. The question is, are we going to allow this? Can we treat these things telemedically? I think we can. Texas is a pioneer in so many areas of healthcare. It can be a leader in telemedicine. I think, go back to the rodeo analogy before, instead of trying to rope it down, tie it up, immobilize it, let's saddle up. You can ride this. You can be a leader, but you also have to allow the innovation to occur, things to move forward.
All right, audience question. Oh, do you have?
I got just one more point I forgot to point out, but we have a gentleman in the audience that's kind of the father of telemedicine. I'd like to point him out, Dr. Ray Dowling. Would you stand up and let everybody see you? They may, if you got some questions, he can probably answer them.
No, I over the last several years, getting large companies, world patient education. And some of the things
Dr. Ray. Come here.
Yeah, you can have our
Microphone.
microphone, yeah.
There's a floating one down there.
I'm sorry. I was the head of a AHEC program in Minnesota years ago, Area Health Education and Coordination, and I set up basically all the treatment standards for many of the illnesses in Minnesota, and that spread across the United States. One of the things that hasn't been addressed here, for one thing, Texans not having phones. I travel all over Africa, and you'd be hard-pressed to find an African without a cell phone in areas where they have service. So I think you're selling rural Texans short if you think they don't have cell phones.
But I'm just saying some of the more rural poor do not have the smartphone.
I don't know if anybody poor that lives on $1 a month. And they,
I'm not sure about that, but we can look at the research.
And another thing, I was an educator at the University of Minnesota. Thanks, Hempen. and at the University of Minnesota, I had 24 residents, but I had a study, and I'm going to be off a little bit on these percentages, but there's a study that shows if you take a group of patients and you let one group be examined only by a physician, you take a group of physicians and you let one group be examined only by physicians and they don't get to talk to the patient, they only make a diagnosis about 20% of the time. You take another group and they talk to telemedicine doctors. We didn't have telemedicine then. You talk to them and they don't get to do an exam, but they make the diagnosis over 70% of the time. So that is a study that's available. I don't know if it can be found again, but it's very, very old, and it speaks exactly to how important it is to talk to the patient. I used it at the University of Minnesota to explain to my patients how important it was to get a good history.
So can we open up for questions? Thank you, sir. Right there, saw her first.
Thank you. My name is Meg Wilson. I'm from Austin. I teach technology commercialization, and I have worked with some of the pioneers in Texas doing telemedicine, and that was in the late 70s and the 80s. My husband worked for a telemedicine company in Texas in the 90s. It's 2016. Excuse me, what's the problem? I teach globalization of technology. Yes, in Africa, everybody has a cell phone. You don't need to research it, I have. I don't know why we don't, partly because we're so stuck to landlines. They aren't. But in Europe, in Africa, in Asia, in parts of South America, telemedicine is common. It's used every single day. They are dependent on it. Africans are telemedicine connecting with Europe. What's our problem?
Does anyone have a response?
I'd comment on that just briefly. Thank you for your work. And you're right, it's old. And Mary mentioned, I believe, in her comments, this demonstration of the technology that occurred about the time she started. It was huge. It would be almost as big as that screen. Today, we wheel that around in a suitcase that you can put in an overhead bin with greater acuity and accuracy and precision, which is what you want with any technology and certainly in medical applications. So that work is very important. What I probably didn't say clearly enough is if you think the pace of change has been fast up to now, you ain't seen nothing yet. Hang on. It's going to be very rapid. Here's the question from a policy point of view. Skype came up. Yeah, we do stuff in Nicaragua by Skype. Skype is doubly encrypted and secure. They just won't tell you how. So they don't meet the law. So can we as people be reasonable about our policies so that technologies can be used? That's really the question that we have to come to. We haven't ever encountered, since I've been at Tech now almost 7 years, in doing telemedicine, regulatory restrictions that restricted what we do. We're way out on the edge. We'll continue to be out on the edge. Where we live, it's edgy. By the way, it's important to you. See, the thing is, the food, the fuel, and the fiber that you all depend on comes from our part of the state. Just look at your garments. 26 counties around Lubbock, Texas produce 1/3 of the world's cotton market. 1/3. We won't talk about petrochemicals, okay? That's why it's important. The technology and the edginess of it, we have to take advantage of as opportunities, and I think we've done a good job of it in Texas.
And I would just quickly say, in working with Dr. Phillips, everything that they're doing out there is absolutely permitted and encouraged under the Texas rules. There's nothing that prohibits that. Why didn't we do it 20 years ago? Well, I was in high school, so I can't tell you. All right, but what I can tell you is that's currently what it is.